Evening, everyone. I'm Dr. Kapil Salgia. I'm a chest physician practicing out of Mumbai at Bombay Hospital. So, cough. It's a symptom which worries most of us on a day-to-day basis. I guess the present scenario, especially since June this year, there has been a outburst of patients who have been having cough. Patients who have been having cough. I guess cleaning is so the clinics have been full with patients having cough, and patients are having complaints of cough which is just not subsiding. So it becomes a very challenging thing for us in our clinical practice to understand what is going wrong, what can we do for our patients to control that cough. Because for a patient, it is just about, I've been going to the doctor 2 visits, 3 visits, but my cough is just not coming under control. So, cough by definition, it is an explosive expiration that provides a normal protective mechanism. You have to understand it's a normal protective mechanism which clears the tracheobronchial tree of its secretions or a foreign body which might be present inside the respiratory tract. So, what happens is on an average around 2.5 liter of air is inspired, the epiglottis closes, the vocal cord shut tightly to entrap the air within the lung, and then the abdominal muscles contract forcefully. They push against the diaphragm. The intercostal muscles come to act, and suddenly the vocal cords and epiglottis open up, and the air is expelled out. The velocity of air that comes out is almost to the tune of 75 to 100 miles per hour. That's the reason during the COVID outbreak, we asked all our patients to cover their faces, cover their mouths, because every bout of cough gave rise to significant amount of expulsion of respiratory droplets, and these droplets were the main source of transmission of infection. Apart from COVID that we saw in our clinical practice, normal viral infections, other respiratory tract infections, and tuberculosis can also spread in the same way. And the extent of spread of the respiratory droplets is very high. So what happens is, so if you are not wearing a mask and you are not protecting or covering your face while coughing, there is a high chance the droplets that you spread might infect all other people. So it's very important for a person who has complaints of cough that he should wear a mask so as to prevent the transmission of infection. And if you as a common person is also attending a function with a lot of people or traveling, wearing a mask will always be protective for you. The shearing forces that develop out of this cough mechanism helps in elimination of the mucus and the foreign materials out important defense mechanism of our airways. It basically doesn't tolerate anything which enters into the respiratory tract, whether this entry of could be a allergen, could be a dust particle, could be a food particle. In cases of aspiration, the respiratory tract is highly sensitive and it would react and generate an episode of cough to expel the particles outside. Sometimes, apart from the defense mechanism role that it plays, there are certain problems that can happen due to excessive coughing. Seen in your clinical practice, excessive cough sometimes can give rise to cough syncope, where patients have those fainting episodes. Sometimes strong bites of cough are associated with severe diaphoresis. Some of these patients sometimes start puking out because of the dry cough, or they try to bring out the phlegm. They get episodes of vomiting arising out of that. Cough fractures are a common entity which has been seen in patients who are having severe bouts of cough. In females, especially stress urinary incontinence, uterine prolapses are well known. Development of inguinal hernias, abdominal hernias due to excessive coughing are certain well-known clinical complications that we see in our day-to-day practice. Also, when you are undergoing a cataract surgery, the Ophthalmologist would not want you to be coughing because it can cause displacement of the lenses. Also, when you are undergoing a hernia surgery, the cough needs to completely settle down because it can give rise to a poor outcome of the hernia surgery. And apart from this, apart from being a defense mechanism and the complications that can arise due to the cough, there are it could be a marker of certain disorders. So cough could be a part of respiratory disorders like asthma, COPD, interstitial lung disease, cardiac failure. So all these things encompass the importance of cough. So when you are evaluating cough, one, you need to know since when the cough is there. So to put it into an acute, subacute or chronic cough, any cough that is present in less than 3 weeks is acute cough. Cough which is present between 3 to 8 weeks is subacute cough, and any cough more than 8 weeks is chronic cough. Any cough more than 2 to 3 weeks definitely requires investigation. A simple X-ray can be more than enough to guide you to some abnormal pathology which is going on in the lungs by doing an X-ray chest. Very commonly, we see patients who have been coughing for quite some time and have been given symptomatic treatment and never been investigated with a simple X-ray as well. And when we do the X-ray, we can find out there is tuberculosis or some other illness. So an X-ray chest in my clinical practice, we don't even need to wait for 2 to 3 weeks. Any cough more than 5 to 7 days on treatment, not getting better, static or worsening, needs to be investigated at least with a simple X-ray chest. Then also important is what is the character of cough. Suppose the cough is bovine with hoarseness of voice. So the commonest condition which could be associated would be palsy of the left recurrent laryngeal nerve. So here the cough is very bovine in nature with associated hoarseness. Sometimes the patient might get a barking kind of cough with hoarseness on stridor. That could be seen in acute epiglottitis, laryngitis or CA larynx. If the cough is present with associated expectoration and there is history of paroxysmal breathlessness, episodic wheezing, or then it could go in favor of asthma. There could be associated paroxysmal breathlessness. If the person has been a smoker and having long-standing chronic productive cough, then you might think the cough could be due to COPD. Then the timing of the cough. Nocturnal cough could be due to asthma, congestive heart failure, gastroesophageal reflux disease, or postnasal drip or cardiac asthma. Early morning cough can also be seen in asthma or bronchiectasis. Bronchiectasis cough might have postural and diurnal variation. Cough which increases on the recumbent position would be also seen in postnasal drip, GERD, or congestive heart failure. The change in the intensity or the phlegm production with change of position could be due to bronchiectasis. So as you see, a history that you take will form a very important role in reaching the diagnosis. Now suppose if the patient has productive phlegm, then you need to ask what is the character of phlegm. If the phlegm is white, it is mucoid, it could be seen as a part of airway disorders like COPD, asthma, or bronchiectasis. If it is mucopurulent, that means there is an underlying infection like staphylococcus. If it is green colored sputum, it could be due to Pseudomonas aeruginosa. If it is reddish tinge, it could be due to Klebsiella pneumonia or Streptococcus pneumoniae. If it has a currant jelly appearance, it is seen in Klebsiella pneumonia, Friedlander's pneumonia. If it is blood stained and frothy, it could be a marker of pulmonary edema. If it is blue colored, it could be due to copper poisoning. If it is black colored, it could be due to a smoker's cough. It could be due to fungal infections like mucor or aspergillus. If it is brown colored, it could be due to an underlying lung abscess. So the color of phlegm can also help you in ascertaining a diagnosis. Also, with cough, you are supposed to ask history of hemoptysis, whether the hemoptysis is streaky or it is significant. Presence of hemoptysis is a common thing which is seen associated with tuberculosis and lung malignancies. It can also be seen in sometimes due to pulmonary edema, due to cardiac failures, or due to Friedlander's pneumonia. Sometimes hemoptysis can also be seen due to coagulation abnormalities, and when everything is worked up, the other differential diagnosis comes are pulmorenal syndromes like Goodpasture syndrome or Wegener's granulomatosis. So, when you are asking for history of cough, by knowing whether the common questions that you have to ask is since when the cough has started, acute, subacute, or chronic, is the cough dry or it is productive? If it is productive, then what is the quantity of sputum, the phlegm? Is there associated blood which is present? Is the cough having any postural variation, nocturnal variation, or positional variation? Is the cough dry? If it's dry, then you can have various differential diagnoses. Like I spoke about asthma, could be interstitial lung diseases, postnasal drip related, GERD related. So these are all the things that you may be able to narrow down depending upon a detailed clinical history. Then, when the cough is acute cough is something which has been less than 3 weeks in existence. So, is the cough dry or wet? Then it could be due to viral infections due to which cause upper respiratory tract infections. If there is nasal congestion, maxillary or frontal headaches, positional headaches, it could mean there is a sinusitis. If there is associated running nose, sneezing, then it could be due to allergic rhinitis. If it's a whooping kind of cough, it could be due to pertussis or the whooping cough, but which is not very commonly seen nowadays. Sometimes an upper respiratory tract infection like a seasonal trigger, a food trigger, or an allergen or a viral infection might aggravate a cough in underlying airway disorder. Like an upper respiratory tract infection may give rise, upper respiratory tract infection may happen, which can give rise to aggravation of underlying asthma, COPD, bronchiectasis. Also, apart from that, acute onset of cough could be due to a pneumonia, could be due to left ventricular failure or a foreign body which is aspirated. Whenever a patient gets hemoptysis, your antennae should raise. You have to investigate immediately. Get their x-rays done. If the x-ray is abnormal or if it's a normal x-ray with hemoptysis, get an HRCT done to rule out underlying endobronchial tuberculosis or endobronchial lesions. If there is associated breathlessness, look for underlying asthma, COPD, bronchiectasis, interstitial lung disease, or pulmonary edema or left ventricular failure. If there is associated fever, then evaluate for any viral, tubercular, or bacterial infections. If it's acute setting, it could be viral or bacterial or a pneumonia. If it is chronic setting with fever, it could be tuberculosis or possibility of malignancy. Is there an associated chest pain? Severe bouts of cough can give rise to cough fractures. Sometimes X-ray chest may help to pick up an underlying pleural effusion or an underlying pneumothorax. So that becomes very important. Is there associated weight loss? When you think of weight loss, the commonest DD comes to your mind is tuberculosis. If the patient is elderly with history of smoking, then it could be a underlying malignancy. So no cough should be neglected. Once you know the cough is present with any of this associated symptoms, immediately investigate further. A cough that is present for more than 3 weeks but less than 8 weeks is basically a subacute cough. Most commonly, this is what we are seeing in our clinical practice at the moment, where it starts off with an acute respiratory tract infection, but the viral trigger or the allergic trigger is causing a persistent airway inflammation and bronchitis. And this bronchitis persists for a long period of time. And most of these patients respond to inhalers with inhaled corticosteroids and LABA. If the cough has been long standing, do an X-ray chest. If it's normal, then depending upon your clinical history, do a pulmonary function test and treat. If there's any associated fever, anorexia, weight loss, do an HRCT chest. Look for underlying symptoms of GERD or post-nasal drip. Apart from that, it could be underlying sinusitis or asthma which might be causing this cough, which needs to be investigated further. Any cough more than 8 weeks. If the person is smoker with no other symptoms, consider COPD. But if the person is having cough with associated anorexia, weight loss, extra systemic manifestations, and has been a heavy smoker, consider CA lung. If the person is a non-smoker, consider tuberculosis. Look for drug history like ACE inhibitors can also give rise to a persistent cough. So when your cough doesn't settle, always look at the drugs that the patient is taken. Do an upper respiratory tract examination to look for any post-nasal drip. Sometimes the cough could just be a manifestation of a cough variant asthma. So if this paroxysmal cough gets triggered with seasonal variation, dust, smoke, weather changes, get a pulmonary function test to rule out underlying asthma. Treat the GERD if it's present, because that is one of the commonest triggers for cough in our clinical practice. So cough is basically a reflex which is initiated by a chemical or a mechanical stimuli in the airways, which is carried by the afferent nerves, which are type C and type 1 fibers from the pharynx, larynx, the larger airways, and the bronchioles. And they basically travel via the vagus and superior laryngeal nerve to the brains. In the brainstem, where there is a cough center, and from where the efferent nerves are sent out to the pharynx, larynx, intercostal muscles, diaphragm, bronchi, and which starts the cough mechanism. If the cough is not taken care of, this cough can give rise to cough syncope, cough fractures, pneumothoraces, loss of consciousness, rupture of subconjunctival nasal or anal veins giving rise to hemorrhages. If the patient has underlying weak spines, it can give rise to dislocation of spines. It can remove the position of catheters, and it can give rise to arrhythmias. Then, what are the neurological causes of cough? The neurological causes of cough could be cough syncope, could be CSF rhinorrhea. Then these are neurological complications that can happen due to cough. Cough syncope, cough headache, especially with a dry cough that you see, or sinusitis related cough which changes on positional variation. Excessive coughing can give rise to cerebral air embolism, can also rupture the cribriform plate giving rise to CSF rhinorrhea. Acute cervical radiculopathy, malfunctioning of the ventricular shunts. Severe cough can at times trigger a seizure and can give rise to gastroesophageal reflux, hydrothorax. Cough is not taken care of. This cough can give rise to cough syncope, cough fractures, pneumothoraces, loss of consciousness, rupture of subconjunctival nasal or anal veins giving rise to hemorrhages. If the patient has underlying weak spines, it can give rise to dislocation of spines. It can remove the position of catheters, and it can give rise to arrhythmias. Then, what are the neurological causes of cough? The neurological causes of cough could be cough syncope, could be CSF rhinorrhea. Then these are neurological complications that can happen due to cough. Cough syncope, cough headache, especially with a dry cough that you see, or sinusitis related cough which changes on positional variation. Excessive coughing can give rise to cerebral air embolism, can also rupture the cribriform plate giving rise to CSF rhinorrhea. Acute cervical radiculopathy, malfunctioning of the ventricular shunts. Severe cough can at times trigger a seizure and can give rise to dissection of the vertebral artery. It can give rise to gastroesophageal reflux, hydrothorax, malfunction of the gastrotomy buttons, inguinal hernias. It can give rise to urinary incontinence, and in musculoskeletal conditions, it can give rise to pneumothoraces or rupture, damage to the intercostal muscles or the bones, giving rise to cough fractures. Apart from that, we can also classify the cough as intrathoracic, that arises from the lungs. So, asthma, where the cough could be dry or productive with paroxysmal or seasonal variation. Lung cancer, the cough would be seen mostly in elderly people, history of smoking with associated constitutional symptoms. In tuberculosis, it could be dry or productive cough, could have hemoptysis with fever, low grade in nature, anorexia, weight loss, or associated pleural effusions. Bronchiectasis would be productive cough, which has been long standing, postural variation with recurrent infective exacerbations. Interstitial lung diseases can have dry cough predominantly, which on auscultation would have fine basal and inspiratory creps. Cystic fibrosis would have childhood history of productive cough with recurrent infective exacerbations. Extrathoracic causes could be allergic rhinitis, characterized by recurrent running nose, sneezing, postnasal drip, which basically occurs more uh, predominantly in the lying down position. GERD could be associated also with bloating sensation. If everything is ruled out, look for history of medication, which can tell you about the ACE related cough.